hopefully understand sexually transmitted infections. Even though this is a maternal, newborn, and pediatrics class, it's important for you to know this information will affect a lot of your patients when you're practicing as a nurse. Okay, 1 in 5 people in the US has an STI. What does this mean? So it's one thing to look at the prevalence and the incidence of sexually transmitted infections on a slide. It's another thing to really bring that down to numbers that we can digest. For example, HSV, herpes, genital herpes is as common as 1 in 12 or 1 in 15 people. And the oral form of herpes, meaning like canker sores or cold sores, it's estimated that about half of adults, teenagers and adults, have oral herpes. So, what's the relevance to taking care of your patients? The relevance is that we have to normalize this for our patients and try to reduce the stigma associated with it. We don't need to be shaming patients simply because they're going to be incredibly embarrassed themselves. And the more you can make them put this into perspective, the better it's going to be for them. Let's take a moment and talk about the difference between prevalence and incidence. So, incidence is the number of, in this case, STIs that are acquired, whereas prevalence means the number of STIs in any given point. Okay, so what makes something like HPV have such a higher prevalence than, say, something like chlamydia? Well, it really all has to do with treatment. So, chlamydia is super common STD or STI, but we can treat chlamydia, and that's why the prevalence, the amount of chlamydia in any given population at any given time is fairly low by comparison to HPV. Whereas the incidence of chlamydia, it can be pretty high, but as soon as we treat it, then the prevalence is lower. And look at HPV, human papilloma virus. Well, that's a virus, and you can't really cure a virus. You can treat it, of course, but you can't cure it. And that's why the prevalence remains high with something like HPV. So if you didn't know the difference between prevalence and incidence before, I would encourage you to kind of bone up on that a little bit, remind yourself what the differences are, and you can see here in this graph why that's really relevant to know the difference between prevalence and incidence. Okay, sexually transmitted infections. I'm going to encourage you to read this article that will hopefully give you a little bit more empathy for your patients related to sexually transmitted infections. And because there are nuances to sexually transmitted infections, I've included some self-study links that might be helpful for you in reviewing this material. So, a sexual exposure chart, I find this really helpful, especially when talking to teenagers who sort of think of themselves as impervious to getting an STI. I find this really helpful to bring this home and make individuals understand the level of exposure that they have when they have sex with a number of partners. So, how to read this chart? So, on the left-hand side, you see the number of sexual partners, which is 1 on the top row or line. And then you can see that if that person is exposed to the same number of partners as you, then you've only been exposed to one person. Okay. And so the risk of getting an STD related to exposure is going to be significantly diminished when you only have sex with one person. Now, is that realistic? Probably not. So let's move down to say 4 or 5 people. Let's say that you have a patient who has had sex with 5 people and their partner has had sex with 5 people. I want you to look then, move over to the right and see that ultimately means if each of them have had 5 sexual partners, that they've been exposed potentially to 31 different people. Let's move down to 10 partners, which isn't unusual. Then slide over and look at that. If you have had 10 partners and your current partner, has also had 10 partners, look at the number of people that they have potentially been exposed to. And then you can see that there's a higher likelihood without protection, or even sometimes with protection, depending on the sexual act, that this person might be more likely to be exposed and obtain a sexually transmitted infection. So this is a startling chart for a lot of patients, and sometimes it can help motivate patients if they're sort of in a bit of denial and maybe not wanting to use a condom to prevent developing or the transmission of a sexually transmitted infection. Okay, so what I'd like you to do when you're studying sexually transmitted infections is to make a list of these STIs and write the causative pathogen. And when I say the causative pathogen, you don't want to just name it. You want to say, is this viral or is this bacterial? Or in the case of trichomoniasis, it's a little flagellated protozoan, okay? You want to know the signs and symptoms. And realistically, some of these STIs are not going to have signs or symptoms. And sometimes, males might have a less likelihood of getting some of these signs and symptoms than even females do. And then next, possible sequelae. What does the word sequelae mean? That means basically what can potentially happen to this patient based on the if they develop, if they have an STI. And then finally, treatment. How are we going to treat this particular STI? And is it curable? I think I mentioned that viral STIs, the most we can typically do is treat them. For example, herpes. We can provide an antiviral to patients to minimize the recurrence of a herpetic outbreak. However, we can't really cure it. And that creates a huge emotional burden for some patients, that it can be really embarrassing and create a problem with how they view themselves and how they view their own sexuality. Okay, so before we talk about sexually transmitted infections, let's talk about what isn't a sexually transmitted infection. So candidiasis or yeast infections, I think most of you probably already know that is not considered a sexually transmitted infection. Can you acquire it through sexual contact? Sure, but it is not considered a sexually transmitted infection because some women can get yeast infections simply because yeast grows in warm, moist environments, and it's not difficult for women who are wearing tightly fitted clothes, non-cotton underwear, who are doing a lot of maybe exercise, to create a really good environment to have the proliferation of yeast. Similarly, bacterial vaginosis, we call it BV. It's usually caused by the bacteria called Gardnerella. We used to consider this a sexually transmitted infection, but what we say about bacterial vaginosis now is it's essentially sexually associated. So women that have sex with women, if they use toys, they can transmit it with sex toys. But once again, bacterial vaginosis or Gardnerella is a bacteria that can normally be present in the vagina, but then what happens is a decrease in the good bacteria, which is typically lactobacilli, happens, and then maybe an overabundance of the BV occurs. So what is the difference between these two really common infections? Well, with With candidiasis, with the yeast infection, you can see on the far right hand portion of the slide, they're going to typically have itching, soreness, they're going to have discharge, but that discharge, and this is important, is going to be a thick white consistency, often like cottage cheese. They could have a burning sensation around the vagina or around the urethra, which might make women think that they have a urinary tract infection. But really, what's happening is that yeast is excoriating the tissue around the urethra. And as the acidic urine passes by that urethral opening, it's causing a burning sensation. Okay. That's why you really have to get a good history from patients, because if you just say dysuria or painful urination, sometimes you're going to be thinking, oh, this is clearly a urinary tract infection, when it could be something like BV or a yeast infection. Okay, so how do we treat this? ATI says fluconazole should not be given to pregnant women, and that's actually not true. We do give fluconazole to pregnant women. We just don't give it to them in the higher doses that we would normally give women who are not pregnant. And then, of course, there's suppositories or creams or tablets, and these can be acquired either by prescription or over the counter, and they're basically just antifungal suppositories or creams. Sometimes women need to be advised that they're not going to just put it in the vagina, because as you can see in this picture here, where they have vulvar candidiasis as well, they might need to rub some of that cream on the outside to treat that candida as well. Okay. You can see here it says a newborn can acquire what from exposure to a yeast infection in the birth canal? Well, the answer to that is thrush, which is yeast of the mouth, and you'll still have that thick white accumulation of material that looks like cottage cheese that will often be on the baby's tongue. So let's move on to bacterial vaginosis. So bacterial vaginosis, they can have some painful urination again. They're going to have potentially some real discomfort in the even just in the pelvis, not necessarily around the vulva or in the vagina. And this is where it can become really interesting, where women will show up at the gynecologic office and think they have an STI or something else is going on with them just because they have pelvic pain, and it could be something as simple as bacterial vaginosis, which is easily treated. Or maybe they're having painful sex and they didn't have painful sex previously. This is known as dyspareunia. So we want to be aware that something as a common vaginal infection can cause pain with sex and pelvic pain as well. So, how do we determine that a patient has BV or yeast? Oftentimes, we can either we can do a test, a PCR test in the office, which is more expensive than maybe just doing a wet mount, where we take a bit of the discharge and look at it under a microscope and then apply potassium hydroxide to it. Potassium hydroxide is going to do two things. It's going to break down the epithelial cells so we can look and see if there's a lot of yeast present or yeast buds or hyphae, which will tell us, hey, yeah, this person has a yeast infection. Or when we apply potassium hydroxide, what we're doing is I know this sounds gross, but this is truly what the test is. There's a whiff test where we waft some of that smell towards our noses. And if it smells fishy, then there's a really good chance that the patient has bacterial vaginosis. But what we're also going to be looking for on that wet mount slide is the presence of something called clue cells. And you can see on the picture here that essentially with clue cells, you have little bacteria that are sticking to the epithelial cells and look like grains of sand. And we can see that under a microscope. And then we'll say that these are what we call clue cells. And that gives us an indication that the patient has bacterial vaginosis. Once again, BV is associated with sexual activity, but it's not really considered a sexually transmitted infection like we once said that it would, or that we once um, categorized it, is what I meant to say. How do we treat BV? Well, we treat with Flagyl. The generic name of that is called metronidazole. And what are we going to tell patients about metronidazole when they take it? If they take it by mouth or even in the vagina, we want to caution them against using alcohol when they use metronidazole because it can actually cause projectile vomiting. Talk about something you don't want to be doing. You don't want to have to deal with BV and have projectile vomiting. Let me see if there's anything else I wanted to tell you about yeast. Or BV. When a woman is exposed to BV or has BV, this can increase her chances of developing pelvic inflammatory disease. And that's simply because there's just a breakdown of tissue, which can make it easier to transmit a sexually transmitted infection. When we're looking at BV, unlike the discharge related to a yeast infection, the discharge tends to be more than the normal amount of discharge that a woman might be experiencing, and it can be thin, white, or gray discharge. And I mentioned the whiff test where you can have a fish-like odor. Well, women who have BV, they will often notice a fish-like smell after intercourse, and that's because the mixing of semen in the vagina when it comes in contact with the BV will create this fishy like odor. And so that's another way that you can screen patients to help determine whether or not they might have BV. I think that's it. Other than metronidazole, BV can also be treated with clindamycin, but metronidazole is usually the go-to. Okay, chlamydia. Chlamydia is pervasive. It is the most commonly reported STI in American women. So chlamydia is caused by a bacteria, Chlamydia trachomatis, and it can be transmitted. Most of us think of it as being vaginal, but it can be transmitted orally or anally. If you ever go to the health department, they tend to do a really good job of asking about sexual practices when they screen patients for sexually transmitted infections. And they're just not just swabbing patients vaginally for chlamydia or gonorrhea or some of these other STIs. If a patient says that they're having oral sex or anal sex, then they might encourage those patients, give them a swab and self-swab their orally and or anally as well. So that's important to know. Incidentally, children who are sexually abused, when they have pharyngitis or some kind of what we might otherwise think as a sore throat, sometimes that's caused by a chlamydial or gonorrheal infection, and that's how we can determine that they have been abused, essentially. So, how do we test for chlamydia? We can do a culture. And incidentally, when we do pap tests on women, oftentimes they will test for chlamydia, gonorrhea, and trichomoniasis at the same time. But also, we can do a NAT test, a nucleic acid amplification test on patients who we are screening for chlamydia. And how is this urine obtained differently than a clean catch? Well, we want all of that bacteria to get in that cup. So you want to make sure that you are not telling those patients not to wipe from front to back when getting a sample for suspicion of like chlamydia or gonorrhea. And I also want you to think how the shame related to being tested for an STI is largely removed when we say to patients, hey, you know what? This is actually can be not a big deal. We can just give you a cup. You pee in the cup. We send that off, and it helps us determine if you have chlamydia or gonorrhea. So, symptoms, as I mentioned before, patients who have chlamydia and or gonorrhea will often have no pain, or maybe specifically women can start having pelvic pain or urinary symptoms or painful sex, okay, or an inflammation of the cervix, which is often why they're having painful sex, or they can have a discharge, an unusual discharge as well. Um, what can happen, the sequelae of having chlamydia? Well, they can get, if they're pregnant, they can get a premature rupture of membranes, endometritis if it's not caught um, during pregnancy. But of course, we always do a screening unless they refuse it in that first trimester of pregnancy for chlamydia. But even women who aren't pregnant, that chlamydia can cause an infection of the endometrium, which ends up being endometritis, which can ultimately, that infection can ascend, meaning move up into those fallopian tubes and cause a pelvic inflammatory disease. Look at this picture in the bottom right where you can see the right, or sorry, on the patient, it would be the left fallopian tube that looks normal. And then the other fallopian tube, which is infected with, we'll just say chlamydia here, you can see how they have pelvic inflammatory disease. And imagine how much easier it is to get an ectopic pregnancy when you have a fallopian tube that is inflamed and infected like that. Perhaps the fertilized egg is not able to make its way down the fallopian tube because of that infection. And then ultimately, that can really lead to scarring of the fallopian tube or tubes, and then ultimately infertility. Let's go back to pregnancy. Once again, one of the effects of chlamydia that infection can cause preterm labor and birth, and then a conjunctivitis, an eye infection, which ultimately leads to ophthalmia neonatorum. You should know those words, ophthalmia neonatorum, which essentially ends up with blindness in neonates or newborns. So we have to be aware that both chlamydia and gonorrhea can cause ophthalmia neonatorum. And what do we use to treat that? If you recall, that would be erythromycin. We give that prophylactically to all babies after birth, assuming that the parents consent to that treatment. So how do we treat chlamydia? I think in class, someone had mentioned doxycycline, which is absolutely a treatment. The problem is doxycycline is not a one and done treatment, whereas azithromycin is safe during pregnancy and it's a one dose treatment. So when we treat patients for chlamydia, we want to tell them to abstain, if at all possible, from sex for 7 days. And then we want to do PT, which is expedited partner therapy. And we're going to be treating sexual partners that they've had in the last 2 months or 60 days. And then we're always going to encourage a test of cure in 3 months, meaning we're going to tell them to come back and make sure that that treatment actually worked by having them do another NAT test, potentially, basically peeing in a cup, and make sure that the treatment worked, or more likely that they weren't re-exposed to chlamydia and got another infection. Generally speaking, when we are screening patients for a sexually transmitted infection related to chlamydia, the recommendations from the Center for Disease Control, or the CDC, is to screen all sexually active females younger than 25, because that is that population that is most likely to have chlamydia. And then again, a neonate, in a neonate, it can cause conjunctivitis and pneumonia if they're exposed to it after delivery. Okay, let's move to the next one. Gonorrhea, which I refer to as chlamydia's bestie, because these two STIs often travel together. In fact, the CDC's recommendation is that if the patient has gonorrhea, that you should automatically treat them for chlamydia, which once again is either doxycycline or azithromycin. And how do you treat gonorrhea? It's a single dose, yay, once again, of Rocephin or ceftriaxone, a cephalosporin. You're going to have them abstain from sex for 7 days again. Do expedited partner therapy, treat those partners that have been exposed, potentially exposed in the last 60 days. But antimicrobial resistance is an increasing concern with gonorrhea. So, depending on the area that patient has been diagnosed with gonorrhea, the CDC or local health department might recommend additional treatment. And then once again, we're going to retest in 3 months because of the likelihood of reinfection. Uh, Gonorrhea is also a bacteria. It's Neisseria gonorrhea, and it, just like chlamydia, can be transmitted vaginally, anally, orally, or through childbirth. We can do a culture just like chlamydia. It can be picked up in a pap test just like chlamydia. We can do that urine gnat test. And patients can have no symptoms. They can have pelvic pain once again, urinary symptoms, meaning burning with urination, painful sex, which is dyspareunia, an increase in vaginal discharge, and maybe even some vaginal bleeding. Gonorrhea was often called the clap back in World War II, and that was derived from a French word clapier, which I think denoted that oftentimes, and this sounds gross, but they would actually put some kind of force down on the penis to try to get the purulent discharge or the pus to come out. Gross, I know, but that's why they called it the clap. What are the sequelae, potential sequelae or effects of a gonorrhea? Well, if the woman is pregnant, she can develop chorioamnionitis. That's an infection of the chorion and the amnion, which can ultimately lead to an infection of the endometrium, which isn't on here, but you can imagine that that would happen. It increases the likelihood of preterm labor and birth, premature rupture of membranes, fetal growth restriction for this. It can even cause sepsis. And then once again, ophthalmia neonatorum, which can cause blindness or sepsis and pelvic inflammatory disease. Okay, trichomoniasis. Notice I made this title green for a reason, and that's because trichomoniasis is a sexually transmitted infection, but instead of a bacteria now, we're talking about a little flagellated protozoan. Look at this picture. These little guys have tails, and you can actually see them under a microscope swimming around. And what's also really interesting is if you do a pelvic exam, basically you put in a speculum and you look, sometimes you can see this sort of thin green frothy like discharge. Look at the little bubbles there on the cervix. And that's how oftentimes we can tell that this patient is likely to have trichomoniasis. The other thing that is sometimes present with trichomoniasis is a strawberry looking cervix. So you can certainly Google that. But when we see a cervix that's dotted and looks a bit like a strawberry, then that will often make us think that they might, and that's really because of tiny little petechiae on the cervix. We'll think that they might have trick. We call it trick. So once again, they can do a NAP swab here. You can transmit trick either through sex, of course, or by sharing of towels or even wet clothing. But we're going to test via a NAT swab. Sometimes we can do a NAT urine specimen, but not all labs, unless we tell them to, are going to look for trichomoniasis in a urine specimen. And that's why we tend to, if we suspect trichomoniasis, we're just going to be doing a swab. So what are those symptoms? We mentioned the thin, frothy yellow-green discharge. They're going to have, just like with perhaps like a yeast infection, they're going to have vaginal or vulvar pruritus or itchiness. They might have pelvic pain once again, sort of like with chlamydia or gonorrhea. And once again, because if that little flagellated protozoan is hanging around the urethra, they might have urinary symptoms. Trichomoniasis can also lead to pelvic inflammatory disease, and we are going to treat trichomoniasis just like we would treat BV, also with metronidazole with Flagyl or tinadazzole. I don't know how to pronounce it, but it's another antibiotic to treat trichomoniasis. Once again, we're going to abstain from sex until therapy is complete. We're going to treat all partners, but there's no test of cure for trichomoniasis like there would be for chlamydia or gonorrhea. And remember, when we are treating patients, whether it's for BV or trichomoniasis, we're going to tell them to avoid alcohol. Metronidazole is also not given in the first trimester of pregnancy because it can act as a teratogen during that during that really critical time frame of fetal development. Okay, before we move on, I included this slide because I wanted to encourage you to look at the types of lesions, skin lesions. This is a pretty straightforward slide that will remind you what all of these terms mean. It's not good enough in your professional charting just to write bump. You need to know the difference between a papule and a nodule. And a crust and a fissure and an ulcer. These are all really important when you are describing things. Instead of saying blister, you're going to say vesicle unless that blister is larger than a half a centimeter. Okay, so pay attention, and hopefully this is review for you, but you really need to know the different types of lesions. If you don't know how to quantify some kind of lump or bump on a patient, then you will write the word lesion and then you will describe it to the best of your ability in a professional way. So please be mindful of that in the future when you're documenting. Okay, genital warts. There are over 100 strains of HPV, the virus that causes genital warts. It's important to know that genital warts aren't always really obvious. But they tend to accumulate in like clusters, almost like cauliflower, but you can have individual warts around the genitals that just look like skin tags, and it's almost impossible to tell for sure by looking at it, and that's why we'll often take a sample and send it off to pathology. HPV, even though this is not a cervical cancer. There are HPV types 16 and 18 are the types that often will cause cervical cancer, and that's why we do pap smears to catch those particular strains of HPV. How do you transmit genital warts? They can also be transmitted vaginally, anally, and orally. So patients can get significant amount of genital warts due to anal penetration. And you can see the perianal warts in this picture in the upper left. And you can see sort of skin tag looking like warts in the upper right. Okay, treatment for genital warts. Again, because this is a virus, there is no cure, but we can provide the patients with imiquimod cream, different types of acetic acids. There's a bichloroacetic acid and a trichloroacetic acid, which we tend to call TCA. And then, of course, we can do freezing, burning, laser treatment, or even surgical excision of genital warts. But it's important to tell these patients that this is a virus and it certainly can return. So they're never going to completely cure it, but they should be on the lookout for a recurrence of these warts. Okay. How do we prevent genital warts? Well, it's the HPV vaccine, otherwise known as Gardasil. And you're going to learn more about this in PEDS, but you might as well get exposed to it. The CDC recommends that children, boys and girls, receive the HPV vaccine between 11 and 12 years of age, but as early as 9 if recommended. And it's generally 2 doses, 6 to 12 months apart. Genital herpes. Genital herpes, I like to call the great imitator because it doesn't always look like the little blisters and vesicles that we like to think genital herpes looks like. So there are 2 types of HSV that can cause genital herpes. It used to be that we would say HSV, herpes simplex virus. One was always the oral canker or cold sores, and HSV2 was considered genital warts. But let's be honest, people have oral sex, anal sex, genital oral, um, genital anal, all kinds of sex. And uh, this HSV, whether it's 1 or 2, can certainly be transmitted. So somebody who has a cold sore on their mouth can have oral sex with somebody on their genitals, and they can transmit this HSV1 or 2 from their mouth to someone's genitals, and that becomes genital herpes. This is really important, guys, because I think a lot of people don't understand that it doesn't have to be a specific virus of genital herpes. It can be 1 or 2, and it can become genital herpes if they're having oral sex. So for that sweet Aunt Sally who wants to kiss your newborn baby, and if 50% of the population has cold sores, there can be something called asymptomatic shedding where maybe she doesn't have a cold sore right now, but maybe she's having that tingling sensation, the prodrome to getting a cold sore, and she kisses your newborn baby, and maybe she transmits oral herpes to your baby. And this is why, as nurses, we want to be aware of transmission so we can educate our patients and protect our patients from potential exposure. So once again, how do you transmit HSV other than, oral, genital, all those different methods that I just talked about? Basically, through any mucosal surface, you can transmit through genital secretions or oral secretions. And once again, a patient can have no known outbreak at present, but they can still shed the virus, basically have asymptomatic shedding, which can cause their partner to get genital herpes. Is it more likely if they have an active lesion? Absolutely. But when we are counseling our patients about not transmitting herpes, if they're those 1 in 12 to 15 people that has genital herpes, you want to tell them that wearing a condom, even when they're not having an outbreak, can really reduce the likelihood of transmission to their partners. Okay, an incubation period can be anywhere from 2 to 12 days. So I have sex with somebody, my partner has genital herpes. I'm not going to be symptomatic maybe this week or even next week, but usually within that 2-week period, I'm going to end up with symptoms which can include itching of my genitals, painful urination, especially if I get herpes around the urethra, painful intercourse. If I have never been exposed to herpes before, meaning I don't have cold sores, I don't have a pre-existing herpetic exposure in some way, then that first exposure, guys, can be so crazy. Patients are going to have incredible pain. They're going to have a fever, potentially flu-like symptoms, and some patients even have to be hospitalized with a primary herpes infection if they're what we call herpes naive, meaning they've never been exposed to herpes before. It's important for you to know that it can really be that bad for patients. It tends to be a lot milder if I already have a history of cold sores and my partner transmits genital herpes to me. Yes, I might have tingling and pain and I might have a few vesicles there, but I'm much less likely to have things like fever, malaise, muscle aches, and basically um, system-wide symptoms related to the transmission of herpes. So, how do we test for herpes? This I find really, really interesting. So, can we do serology, meaning can we draw someone's blood and see if they've been exposed to herpes? Well, sure we can. But here's the rub, guys. Let's say I draw blood on somebody who has already cold sores, okay? And it comes back positive for HSV. Does that mean that they have genital herpes? No, it doesn't. It just means that they have been exposed to herpes and potentially they have genital herpes, but maybe they only get cold sores and they don't have genital herpes. That's why serology can be so problematic when we're testing for sexually transmitted infections. And so, for that reason, serology testing is usually not recommended. Another thing we can do, which is the gold standard, is if a patient comes in and in there that they're in that point after herpes exposure that they have these vesicles, these little blisters, we can unroof, basically break open those vesicles and take a swab and rub pretty hard, which is really painful for a patient, okay? Rub really hard and send that swab off for a culture and really find out, a viral culture, and find out if potentially that patient has herpes. However, if they don't come in when they have these little blisters or vesicles, and we try to do that, the likelihood or the sensitivity dramatically drops, and it makes it a lot harder to really confirm that the patient has genital herpes. We can do a PCR test where we're swabbing as well, and that is more sensitive than the viral culture. But generally speaking, the viral culture is the gold standard. So just because we swab a patient with either a viral culture or a PCR test and it comes back negative, the specificity is not really there like it should be sometimes. And it doesn't mean that patients don't have genital herpes. It might just mean that we didn't get a good sample or catch them at the right time. So this can be really frustrating for patients. But if it's a really bad burning case of vaginal or vulvar burning or penile burning. Um, they have crusted areas where they used to have blisters. That's pretty indicative of genital herpes. And sometimes we will just treat the patient and maybe have them come back if they have any further outbreaks. Um, I talked about a prodrome for genital herpes, and that typically consists of tingling and pain that is followed by these vesicles or pustules that will ultimately crust over and heal. So when we suspect that a patient has genital herpes, we want to give them the information to be aware, whether it's oral or genital, that if they notice this tingling sensation around their lips or their genitals, that if they have an antiviral medication on hand, they should take that preemptively to help minimize or prevent an outbreak. And that's what we do with women who are pregnant. If you recall, around 35 or 36 weeks gestation, women who have a history of genital herpes, we are going to be giving them an antiviral therapy like acyclovir to be taken on a routine basis to minimize the likelihood that they're going to have a herpes outbreak when they go into labor. because if a woman has a herpetic outbreak on her genitals when she goes into labor, that's an automatic ticket to get a C-section, because we do not want the baby exposed to herpes as it is coming out of the birth canal, because that can lead to a significant infection in the baby, and that can even ultimately cause death. So we definitely want to screen our patients to make sure that they don't have a herpes outbreak when they're going to have to give birth. All right, let's move on to syphilis. Syphilis is also caused by a bacteria, Treponema pallidum, and the transmission that's why it's called an STI, is sexual contact. Um, Testing consists of serology, and we will talk about that in the next slide. Treatment is always penicillin G, that's the gold standard, and we're always going to treat sexual partners for syphilis because there is a latent period if a patient has been infected over the last there's going to be a latent period where if a patient has been infected and we missed the primary and secondary stages of syphilis, that they might not have any symptoms whatsoever, and they can continue to transmit it to other people. So I always find syphilis really fascinating. So when a patient is initially exposed to syphilis, they're going to have a painless chancre. So what's a chancre? And here's where you go back to that other slide that I gave you that showed the different types of lesions. A chancre is basically an ulceration of tissue, an erosion of tissue. But unlike herpes, which can be super, super painful, where they have these little vesicles or blisters, when a patient gets syphilis in the primary stage, they'll get a chancre, but it's painless. So whereas a male with a chancre can see his penis and see his scrotum and see if there's a chancre there, that's the entry point for the bacteria, Treponema pallidum. So if a woman has a chancre in the vagina, you can imagine that she has no idea that she has had potentially, she has an STI or an exposure to syphilis. Maybe she's lucky enough to have it on the vulva and she notices it, but unless you're really putting your hands down there and feeling around or taking a mirror, plenty of women don't realize that they have a chancre. And that can last, the primary syphilis can last anywhere from 3 to 6 weeks. Then, after that 3 to 6 week period, if it has not been caught and treated, then we move on to the secondary stage of syphilis, which is usually a rash on the palms of the hands or the soles of the feet. And that's what you see in this picture here. Additionally, that infection can progress to patients having a sore throat and lymphadenopathy, which is swelling of the lymph nodes, and even flu-like symptoms. It can progress to patchy alopecia, which means patchy baldness. So you can imagine that these are really indicative signs potentially of syphilis if a patient comes in with patchy baldness or alopecia and a rash on the hands or feet. Unlike lymphadenopathy or flu-like symptoms, the rash on the hands and feet and the patchy alopecia do point more specifically to syphilis than those other non-specific symptoms. The infection can lead to renal insufficiency, and you can end up with ocular manifestations of syphilis that includes uveitis, retinitis, and optic neuritis. Okay, I mentioned this before. If you don't catch syphilis in the primary or secondary stages, then it will move into a latency period where they won't have any symptoms, but they can still be quite infective for up to a couple of years. finally, and you hope that it doesn't get to this point, but some patients go an entire lifetime or many years with being infected with syphilis. And the tertiary phase is really where we call it neurosyphilis because they end up with central nervous system symptoms, which includes neurologic symptoms, once again, ocular symptoms, um, otosyphilis, even cardiovascular symptoms and tumors of the skin, bones, and liver. And at this point, if we've let it go on this long, the damage is done and it's usually not reversible. So, syphilis, because it can be more complicated and it has all of these stages, what kind of testing is done for syphilis? So typically, if you recall, for women who are pregnant, we do the VDRL or the RPR, the Venereal Disease Research Laboratory Test, or the Reactive Plasma Reagin Test. Those tests are non-treponemal tests, so they're not specific for the bacteria Treponema pallidum. So that's really typical. But lately, the paradigm of syphilis testing has shifted to go from the non-treponemal tests, which aren't specific to syphilis, to the treponemal tests, which are specific for syphilis, which are the FTA-ABS, the TPPA, and the EIA tests. And you can imagine, depending on the presentation of the patient, that we might prefer a treponemal test if we're really sure that a patient has been exposed to syphilis and we want to start with a treponemal test and then maybe move to the non-treponemal test next. It's important to know that the order has changed recently where you can go from one to the other. I mentioned on the last slide what happens if syphilis is left untreated. Well, they progress to the tertiary phase, and they can go through stages that eventually lead to blindness, dementia, which is a CNS kind of symptom as well, and even death. So once again, primary stage can last 3 to 6 weeks. Secondary stage is characterized by usually by an itchless body rash, palmar and plantar rash, and that can last for several months. And then it can progress to latent symptomless stage for a few years, and then even decades later, tertiary syphilis can rear its ugly head, and that results in multiple organ damage. Okay, HIV and AIDS. I'm going to let you watch this really great video from Level Up RN, and we'll talk about HIV briefly. Some things that I want to emphasize that are talked about in your ATI book. You should know that any pregnant women that have HIV, we're going to minimize invasive procedures like an amniocentesis and an episiotomy because we want to avoid the risk of exposing the fetus to maternal blood. They're going to be doing frequent viral load levels during pregnancy to see what a woman's CD4 count is to determine whether or not she can deliver vaginally. If her CD4 count is high, then they're going to deliver by C-section to hopefully minimize the baby's exposure to HIV vaginally when it's being born. Let's backtrack again. Additional procedures that we would minimize or not do to a woman when she's in labor if she has positive for HIV or any internal monitors, vacuum extraction, or forceps. Those are called operative vaginal births. We wouldn't do that for a woman if she were in labor and having labor dystocia, whereas a woman that didn't have HIV, we might implement those, if they might be an option to use a vacuum or forceps. We would just go right to a C-section if there was labor dystocia for a woman who had HIV. Um, so with both hepatitis B and HIV, we're not going to give injections right after birth or do blood testing until that baby has been bathed. So keep that in mind. We want to minimize transmission. So we're going to bathe these babies sooner rather than later if they have Hep B or HIV. Usually, the woman who has HIV is going to receive antiviral um, medications, which are basically antiretroviral therapies. And usually that amounts to IV zidovudine during labor to minimize the baby's exposure to or to decrease the viral load, essentially. It's important to know that in the US, we do not encourage women to breastfeed because of the possibility of transmission of HIV. But in some third world countries, the World Health Organization says, yes, it's reasonable to allow women to breastfeed their babies if they're HIV positive. And guys, that really just comes down to the likelihood of survival. If you're expecting a woman in a third world country that has HIV not to breastfeed, and she doesn't have exposure or the means to buy formula or have someone else breastfeed her infant that's not HIV positive, well, that baby's certainly going to die if they aren't breastfed. Whereas if they're breastfed, they at least have a chance, and there's a chance that that HIV might not be transmitted to that newborn. Okay, so we can probably skip over scabies because it's really not an STI, but your book did mention it as an ectoparasitic infection. Mites, bed bugs, and scabies are all ectoparasitic infections. I just thought it was interesting, and you should know this for peds, so I just included this on the slide. You can always look back at it later. Okay, pediculosis pubis, or pubic lice, or what we commonly refer to as crabs. It is a mite or a form of lice that is sexually transmitted, but it's not a sexually transmitted infection. It's more of like an infestation. And that's because of how it's transmitted. It can be transmitted through sexual contact. However, it can also be transmitted with uh, like towels, but it is usually direct contact with another human being. In children, they can have an infestation of their eyelashes or eyebrows, and any of these infestations, these ectoparasitic infestations, are more likely in crowded environments. So that's important to keep in mind. So, usually after infestation, the symptoms appear within about 5 days, and they're going to have itching of that in that mons pubis area where all that hair is, where the pubic hair is. The skin is going to be irritated and red, and even maybe bloody in certain areas. If you're looking at a patient, you might see little white dots or black droppings. A patient might notice little black spots, which are lice droppings in their underwear. And the lice eggs are really often hard to remove, and we have to get a fine-tooth special knit comb to remove some of those lice eggs. The other thing that patients might notice are pale bluish spots on their thighs, buttocks, and lower abdomen. I believe that's from the bite of the pubic lice. And once again, with pubic lice, the infestation can happen not only in the genital area around the pubic hair, but also on eyelashes, eyebrows, armpits, and on men beards and on their chest hair. So that's interesting to note that those pubic lice can migrate to those other areas of the body. So how do we treat that? Um, Permethrin cream, this special shampoo, pyrethrin. I can't pronounce this. Pyperonyl butoxide shampoo. Oral ivermectin is another treatment, or you might have heard of Quell, which is a Lindane shampoo. So, what are we going to tell patients to do if they freak out and they realize they have pubic lice? Well, the first thing they want to do is thoroughly wash bed linen, towels, and underwear and clothing in hot water. They shouldn't have sexual contact until at least 7 days after starting treatment. And in terms of treatment, we already mentioned the medication and removing nits and eggs with that fine tooth comb. They shouldn't be sharing personal items or accepting personal items from others. And then in the end, they should also be meticulously vacuuming carpets to prevent recurrence of infestation. But that's actually more of a scabies than a pubic lice issue. But in the end, it's still not going to hurt and minimize transmission. Um, just as you would treat any sexual partner for any other sexually transmitted infection, you would want to treat any partners that have potentially been exposed to pubic lice as well. And talk about a bummer to have to tell somebody that you have pubic lice. But once again, to minimize the stigma related to this, because it is more of an infestation and it might help someone's sort of mental stress load if you tell them that, hey, this is an ectoparasite. This can be really common in certain areas and highly populated areas. It is sexually associated, but luckily we can actually cure this, unlike some other sexually transmitted infections. Okay, it's important to know that there are disparities in sexually transmitted infections. For example, even though in the US, um, uh, the total number of cases of STIs in any given population might be low in certain ethnic populations, it might be proportionally higher. For example, it says here in 2021, 31% of all cases of chlamydia, gonorrhea, and primary and secondary syphilis were among non-Hispanic Black persons, even though they made up only 12% of the population. So this is a disparity. They make up 12% of the population, but have perhaps 31% of the cases of chlamydia, gonorrhea, and primary and secondary syphilis. Similarly, American Indian or Alaska Native persons only have 0.7% of all live births in the US, and yet they have 3.6% of all congenital syphilis cases. That means that this patient population of Alaskan Natives, or American Indians perhaps didn't get the screening they needed, that RPR and the VDRL, and then they ended up with newborns that acquired syphilis during pregnancy and acquired congenital syphilis. Men who have sex with men are also disproportionately impacted by STDs, including gonorrhea, primary and secondary syphilis. And one of the reasons that this happens is that if they're having receptive anal intercourse, the rectum is not really, it's very thin compared to, say, the vaginal mucosa, and it's much easier to have micro tears there in the rectum or around the anal area, and that makes the transmission of STDs that much easier. That's why in the population of men who have sex with men, a lot of these males are aware of the increased incidence and likelihood of transmission of STIs, and a lot of this population of gay men are much more proactive about getting tested for STIs on a routine, if not yearly basis. Okay, the other six P's, if you remember the five P's related to labor, now there are six P's. Actually, technically, it was supposed to be five P's of STI and sexual activity screening. But I added another one that I think is important, especially in light of the fact that we're going to be talking about interpersonal violence or domestic violence. So we want to, when we're talking about STDs and sexual activity, we want to talk to our patients about partners, the number that they've had of partners they've had in the last, say, 3 months, and the gender of their partner, because that has a bit to do with their practices and exposures. We're also going to talk about their past history. Have they had STDs in the past? You know that some STDs aren't curable, and that has relevancy, right? And how you're going to talk to your patients and potentially treat patients. And then three, practices. Sometimes we just like to think of this sort of heteronorm ideas of, penile and vaginal penetration, but people have all kinds of different sexual practices. And when you are talking to them, it's important to be neutral in your expressions. They might tell you something you've never heard before, but you don't want to increase their likelihood of not being open with you, because you want to provide the best care for them. So you want to tell them that it's okay, or make yourself approachable in a way that they can tell you about where they might have had their sexual contact, whether it's oral or anal or vaginal, or I don't know, in their ear. You just never know. Okay. So be open to that when you're talking to them about practices, and you might even want to just give them examples so they know what you're talking about. And then injection drug use is important, because something like hepatitis C, which is often transmitted through injection drug use, can be transmitted, especially for a pregnant woman, to her fetus. And we want to know if potentially we should be screening for something like HIV and Hep C as well. Protection. How frequently do they use condoms? Sometimes people are not going to be forthright because they think you're going to be judgmental. So you have to let them know that the reason that you're there is just to collect the information, and it's okay for them. In fact, you encourage them to be honest so that they can receive appropriate care. Immunization status. It's going to be really helpful to know if they had the HPV vaccine, right? If they're showing up with a cluster of lesions that is really looks a lot like cauliflower, and makes you think, hey, maybe they have HPV, the genital warts version strain of HPV, and it'll help to know what their immunization status is. You want to know if they want to prevent pregnancy. This is something that sometimes we assume, particularly with women, that they want to prevent pregnancy, but is it even a relevant issue if they're only having sex with other women? Well, obviously the answer is no, but there are a certain population of women who will label themselves as lesbians, but then will still continue to have sex with males. And so that's why you want to specifically ask about practices, because you don't want to make assumptions that just because someone labels themselves as something, that they aren't having practices that would increase their risk of getting pregnant. And then finally, like as I mentioned before, we want to talk about permission. You want to talk to your patients about the importance of obtaining and giving consent. And this is particularly important potentially in your adolescent population. Okay, so putting it all together, you are the nurse at Eastern Idaho Public Health, and you're tasked with providing contraception information to a sexually active 16-year-old male. What information do you want to collect? Well, you're going to go back to those 6 P's, right? 5 P's initially, um, and ask about how many partners have they had sex yet. You don't want to make any assumptions, and the only way you're going to tell potentially is by asking about practices. Sometimes even adults think that they are engaged in sexual activity, and maybe it's something that's not really anything that be worried about in terms of exposure. For example, maybe it's just like fondling breasts and you're not worried about an STI if that's what's going on. Um, so go back to the 5 P's. What information will you provide this 16-year-old male? You're going to want to talk about STIs, right? You're going to want to talk about the use of condoms, and you're going to want to teach that adolescent about how to use and put on a condom, which we talked about previously. You're going to want to have a reservoir tip. You're going to want to tell them that it has to be on an erect penis and that they have to remove it while the penis is still erect if they're using a condom. Um, and then you want to talk to them about the permission as well, that last P. And then how will you provide information to an adolescent to ensure that he understands? And if you're going to talk, once again, if you're going to talk about condoms, maybe you're going to break out the banana and you're going to actually have that teen put the condom on the banana so that they can demonstrate and you can document that they've demonstrated the correct way to place a condom on ultimately the penis. So hopefully this was helpful. Don't forget to review the information in your ATI book, and good luck on your CMS.